I thought I was, oh, there, someone got it.
I just told I don't know how it worked, but I literally told my computer to record it to your cloud, so you will get the email.
Okay, that is so weird, but thank you for
Hey, if
figuring
it
that
works, it
out.
works. It works, it works.
Yes. Okay. So good morning, everybody. Thank you so much for joining us today. Tai and I are really excited to share not only kind of the basics of disaster behavioral health, but at the end, we'll have some time to share a little bit about the disaster behavioral health response that our University of Minnesota Medical Reserve Corps disaster behavioral health response team um, did a few weeks ago. So I'm Courtney Wetternach. I am the Medical Reserve Corps manager for the Health Emergency Response Office at the University of Minnesota. I also teach a class on public health emergency preparedness and response in the School of Public Health. I've been doing public health emergency preparedness since 2002. So I've been through many different iterations of planning for disaster behavioral health, but then also using it in some of the responses that I've been involved in. Tai, I'll have you introduce yourself.
Sure. My name's Tai Mendenhall. I'm a professor here at the University of Minnesota. This is my third round because I did undergrad here, then I went away, did my graduate school here, went away, and then came back now as a faculty member. I originally got involved in this work with the September 11th attacks, and that was when I was a student. And when I came back as faculty, as the MRC was forming, I joined it in that capacity. And like Courtney, I've been involved in a variety of different responses over the years. And I'm glad to be here and engage with other folks that are interested in like-minded work.
So the agenda, we'll just kind of be doing an overview of disaster behavioral health. Tai will talk about types of disasters and how if they impact mental health or disaster behavioral health. We'll talk about psychological first aid, and then we'll have a little bit of time at the end for the Annunciation School shooting, and we'll try to save some time at the end for questions. A few learning objectives, and you can use these if you are going to be requesting CEUs. So we want you to define disaster behavioral health and its key components, understand the types of disasters and their impacts on mental health, learn the principles of psychological first aid, and apply the learning to a case study, the Annunciation School shooting. So what is disaster behavioral health? Several variations on the definition, but the one I think is most fitting for this audience is that disaster behavioral health addresses the psychological, emotional, and substance use issues that affect survivors, responders, and communities following a disaster. It is an integral part of the overall public health and medical response system, and it addresses the impacts of natural and human-caused disasters in all phases of emergency management, mitigation, planning and preparedness, response, and recovery. The Substance Use and Mental Health Services Administration, SAMHSA, defines it as the understanding and provision of mental, emotional, and substance use interventions for people and communities affected by disasters. So what is it not? So using a public health model, disaster behavioral health is immediate short-term response after a traumatic event. Disaster behavioral health focuses on the mental and emotional well-being of an entire population or community rather than just diagnosing and treating specific individual mental illnesses. It is rooted in public health principles. So disaster behavioral health practitioners are not doing individual therapy, nor are they diagnosing specific conditions such as PTSD. I've intentionally mentioned that disaster behavioral health uses a public health approach a few times now. focusing on the mental and emotional well-being of an entire population or community. While clinical care is available for individuals who need it, disaster behavioral health primarily helps people develop coping strategies and access natural support systems to build resilience and speed up recovery. Services are provided to all who are affected by a disaster, including first responders, volunteers, relief workers, and emergency managers or others that are assisting in the disaster. Interventions like psychological first aid are designed to be short-term and supportive, helping to reduce initial distress in the aftermath of a traumatic event. And finally, disaster behavioral health aims to foster overall mental health, reduce substance misuse, and minimize the risk of individuals developing more severe long-term conditions like PTSD or depression. TFA, psychological first aid, is a foundational skill set that allows individuals to provide immediate compassionate support to those in disasters. Psychoeducation is informing people about typical emotional responses to the disaster, and it helps normalize their experiences to promote healthier coping. Supportive listening is engaging in compassionate, non judgmental listening to help survivors process their feelings and acknowledge their situation. Stress management is providing tools and techniques to help manage stress, anger, and other challenging emotions following a traumatic event. Incorporating disaster behavioral health ensures more compassionate and effective responses, leading to more resilient communities. Disaster behavioral health efforts focus on the unique challenges faced by at-risk populations and people with access and functional needs. It can provide targeted support, ensuring that vulnerable groups such as children, older adults, and those with pre-existing mental health conditions are included in all planning and response efforts. So some challenges, immediate and short term, there could be an overwhelming demand for services. So the scale of a disaster can create a sudden surge in demand that overwhelms the capacity of the existing mental health infrastructure, which may already be under-resourced. Service disruption. So disasters can damage or destroy healthcare facilities, disrupt supply chains for medication or other supplies, and make it difficult for staff to get to work, disrupting our existing mental health care services. First responders, healthcare professionals, and other emergency workers are vulnerable to their own stress, compassion fatigue, and burnout. Without adequate support, this affects their ability to provide care to others. And then logistical barriers. Delivering services can be hampered by factors such as damaged roads, lack of transportation, and the need to triage and manage victims in temporary or unfamiliar settings like shelters. Challenges affecting survivors and communities. So there could be gaps in accessibility. So geographic barriers, especially in rural areas, can limit access to services. Many vulnerable populations, including the elderly, people with disabilities, and non-English speakers, face additional obstacles due to inadequate finances, lack of insurance, or language barriers. And those are just a few examples. Stigma. So in some communities, there is a stigma associated with mental health services that prevents individuals from seeking help, even when they are in significant distress. This is often compounded by cultural factors or a desire to handle things on their own. Disasters can cause family separation and the displacement of residents, disrupting the natural support systems and social connections that aid them in recovery. This also relates to cultural challenges where interventions may be culturally irrelevant or fail to recognize existing effective support networks. And then crisis of faith. We saw this in the Annunciation shooting. Why does God or your higher power let this happen? I don't have an answer for that. Communication and coordination challenges. Poor interagency communication can cause lack of coordination between emergency management agencies, between public health departments, healthcare providers, and other organizations, and can cause chaos and delay in and delay effective responses. Excuse me. Conflicting information. So during a disaster, contradictory information can increase confusion and worry, making it difficult for responders and survivors to make sound decisions. And then this is a big one, lack of identification. So in the chaos of a disaster zone, behavioral health professionals may lack clear identification, making it difficult for people to distinguish them from untrained volunteers and know whether they are who they say they are and that they are a licensed mental health provider.
Okay, I'll jump in. Thank you, Courtney. I think a lot of that, just in terms of setting the stage, I'm going to project here, sounds um, like great information. I think that when we connect it with some of the stories regarding the Annunciation, it'll stick even better, because a lot of the details in terms of what some of that looks like, or some of that means, are going to be a lot more real with the narrative. So I want to make sure that we can give information and space, because we learned a lot, even though we've been doing this a lot over the years. I've never been through a deployment or an experience where we didn't walk away with new learnings. As the getting into it then, with the demographics, or my understanding of a lot of the folks here that are on the call, the different hats that you wear, the credentials that you bring, what do I do? How is this going to look on the ground in terms of my own experience and my own engagement with folks? Disaster behavioral health is centered, or it can be launched as some kind of foundation from a variety of different organizations. And here's a list. Some of you connected with some or multiple of them. Government agencies, NGOs like the Red Cross, the Green Cross, ICISF, for example, any variety of voluntary organizations, the Medical Reserve Corps, or Medical Reserve Corps, plural, are examples to that, alongside people that have day jobs in healthcare systems and that are going to be deployed as a part of that larger frame that is or isn't officially with your day job, but is still connected with where your professional home base is. So then if we continue going then in terms of what that looks like with the teams themselves, we have, and the professor in me always wants to go off on tangents and then lose time. I'll try not to, but huge differences in the literature in terms of what multidisciplinary work means versus interdisciplinary work, and we have both of those there, because multidisciplinary means you're all there. It doesn't necessarily mean that you're working together. We start there, but then especially as it relates to mental health, we work very hard to get out of some of the turf battles between our sibling disciplines on who's better. Psychologists are better, family therapists are better, social workers are better. We get socialized into thinking that through graduate school, and then are told to collaborate after we graduate, and it can be really difficult. The interdisciplinary nature of these teams is such that we purposely put diverse disciplines together, because we do better work when we do work that way. And there's a lot of empirical support for that. When you have a psychologist with a psychologist, for example, on a two-member team, they don't do as well as a psychologist plus a social worker, etc., or any other combination. We also involve purposefully people that don't have letters at the end of their names, because the local school teachers and the administrators for a variety of different types of hosting organizations, neighborhood organizations, churches, etc., are oftentimes going to be there longer than we are, and they have a lived experience and wisdom centered to that place that really represents an essential part of the ways that that these teams hit the ground. running, but then also continue and carry on the work in more of a long-term manner after we go back to our day jobs and go on to other things. So next slide. The ways that we are responding, a lot of times people ask, if you watch the news, you can probably see us because the big, large-scale stuff gets a lot of attention, but we also deploy to smaller scale things a lot, and we're doing different types of training to get ready for that. It's better to prepare than it is to repair. And although that baseline clinical license is super important, most of us that train to achieve that, whatever the L is, the LP, the LICSW, the LMFT, the LADC, etc. Those are situated primarily in private practice centric models where it's a pull intervention. We're in an office, people come to see us at 3 o'clock every Wednesday, and the extension of the push interventions, oftentimes where we're going to people, or the specialized pull interventions like family assistance centers, is not something that you get trained for in graduate school. So additional training through FEMA, Red Cross, ICSF, Green Cross, etc., is really necessary and required to be able to do this work well. So next slide. The nature or the situation that we do this in ranges from small to large. Emergencies could be just you and your family. Nobody else knows. Nobody else cares. You're not going to get a lot of, and I don't say that in a bad way. It's just that emergencies can be any size, where disasters are very large scale, oftentimes have a lot of visibility and are impacting folks, especially psychologically, or in manners that are going to require different skill sets than that individual patient, individual couple, individual family in your individual room that your baseline license got you ready to do. So we go next slide. So the disaster types are really an important part of some of this training. Natural disasters, human-caused disasters are different. And so if we start with human-caused, although, again, there's overlap, of course, trauma can manifest across a variety of different things. Human-caused disasters, and you can just start scrolling through the pictures here just as ways to do this, are oftentimes connected to this sense of anger, this sense of injustice, this sense of confusion as to why and who caused this. Natural disasters are easy to chalk up to acts of God. You could do that with a hurricane. It's hard to chalk off somebody not maintaining structures well that collapse to kill people, or people that walk into churches and murder your kids. That's a tough one to chalk off as an act of God. So there's going to be a lot different types of emotional responses to human-caused disasters that are not extant within natural disasters, that are important to understand, important to engage with, and important to have in the back of your mind regarding any and everything that you say. We see this across medical emergencies. We see this as it connects to compassion fatigue and responder burnout across healthcare. And a lot of our patients, or the recipients of our care, don't ever see this, but a lot of times it's not uncommon to have our teams falling apart at the same time that they're putting on a particular type of face, or patient facing that the folks that we care for never see. Now, as we extend then into natural disasters, and we can look through some pictures here, you can also think, okay, well, if are human-caused disasters worse? No, they're different. Natural disasters oftentimes overlap into what we call crisis of scope. Human-caused disasters, as horrible as they are, tend to be relatively small in terms of the immediately impacted area, whereas natural disasters oftentimes are putting our responders into positions where we too are sleeping under the mosquito nets. We too are hot. We too are not able to get into the creature comforts, because unlike human-caused disaster, where you go on site and you do work and then you go home, or you go to the hotel nearby that your hosting organization has set up, natural disasters oftentimes don't lend themselves to that. So the likelihood of burnout, compassion fatigue, and exhaustion can be higher here because the baseline tenets of self-care, the baseline tenets of um, recovering and processing, et cetera, are just simply aren't going to look the same. And as we think about um, the the randomness of natural disasters, oftentimes there can be a larger sense of fear, potentially on when is this going to happen? How am I, going to protect my family if it really kind of feels like I'm an ant on the anthill waiting for something to happen? Um, Whereas oftentimes human-caused disasters, as horrible as they are, there can be this better sense of, okay, what do I need to do to at least keep myself out of harm's way? Natural disasters don't work that way. There's a lot of types of disasters that are arguably both, and this I think COVID would probably be one of the most recent examples of this. Certainly, our experiences with the politicization of not only disease, plague, famine, mud, then going off into things that are, are they natural? Mudslides, hurricanes, natural events. Is this really an act of God or is it people? Arguably all of that. And so now what we're having as it connects to these types of disasters is everything that I just said about human caused and natural is happening at the same time. And at least one of the things that we're starting to find out with some of our emerging empirical work is that when the disaster that we're responding to cannot be conceptualized or narrated in a very clear human cause versus natural, it's arguably even harder. So if we can go through the rest of the pictures, yeah, here, then in what I just said, what is it and how is it experience? Humans are complex creatures, and we perceive things in a variety of different ways. And if we go into then trying to make sense of, okay, we as responders are going to go in and try to respond to this. What are we responding to? Perspectives vary, and if we you can go on to the next slide, the um, biopsychosocial spiritual complexities of what trauma is. I mean, if you break a leg, yeah, I mean, I suppose you have trauma to your body, but is witnessing or experiencing the, oh my gosh, my child was at that school, are they okay? Trauma too, absolutely. If it's trauma to you, it's trauma. And our fields plural, have really wrestled with this notion of how we and where we land and where we engage with folks around this. So go to the next slide. The psychological trauma as it connects to a variety of these different types of things. And there is no exception to this. In social science, usually we have to say things vary, and you've already heard me say it. There are some things that don't vary. And because of the multiple ways of defining trauma, the multiple, is it human caused, is it natural, is it both, who and how and in what ways is this manifesting? And then humans are connected to each other because we are designed by nature or God or however you see this as social animals, social creatures. Our psychological and behavioral outcomes connected to any of this stuff is always, it isn't sometimes, it is always bigger. And so those of you that are old enough, for example, to remember the 9/11 attacks, I mean, I remember that was the first time, excuse me, that I saw this happen outside of a textbook, is, about 3,000 people were killed that day, but the world was impacted. And we heard it here in Minnesota that, oh, I was the neighbor of somebody that went to school with somebody that lived across the street, that somebody was the dentist of somebody that was in New York. We were literally trying to be connected to the event. Everybody was wondering about safety in airports. A couple weeks later, nobody, even since then, has been able to get through security without at least asking the question, do I need to take my shoes off? Because there might be, a fear or a connection, with future attacks. Psychological is always bigger. We saw that with the Annunciation school shooting. As soon as we overlapped school shooting, because arguably I think a lot of, unfortunately, the folks have been kind of desensitized to school shootings. Now it was in a church, and now it was different. And then around the world, people are impacted when arguably the number of people that had medical outcomes, the folks that were killed, the folks that were injured, very, very small number. So we go to the next slide. When we get into the psychological experiences of people that we engage with, we also need to be careful about what the media does, which is very not empirically supported, to what we see with research, that the fear, the distress, the worry, yeah, I mean, it could be with people that were right there. It could be people that are around the world. Behavioral changes, smaller. So using alcohol to sleep at night, starting smoking again. A child that was potty trained a couple of years ago is starting to wet the bed again. Biting your spouse's heads off, being super irritable, not performing well at work, going to work, and then not doing anything when you get there. A variety of different behavioral changes are also relatively normal in response to this. But is it PTSD? I mean, the news, I mean, an event happens this morning, and by noon, everybody has PTSD according to the news. That is not possible. That is not how these diagnoses work. But that's how things get, advertised to the world. And so it's very common for people who are reacting normally to an abnormal situation to presume the worst, that they're somehow like damaged goods now, that they're going to have PTSD that for years they're going to struggle with, because that's what the media has told them. We as responders are oftentimes in roles of psychoeducation to say, no, you do not have PTSD. That is so important as it connects to a lot of the responses that we do. Information is power. Sometimes when you go to the doctor, the best thing that your physician can tell you is, no, you don't have cancer. Oh my gosh, that's what I was losing sleep over. I thought I had cancer. And the doctor sometimes, maybe even kind of thought it was odd that you asked, because from their perspective, it's so obvious that you don't have cancer. But from the perspective of a lot of the people that we work with, they don't understand that. Something happens this morning and they have PTSD by lunchtime. So we go to the next slide. Across these interventions where we go to people and people come to us, this is where we start to integrate into PFA, psychological first aid stage left. So if we can go to the next slide. And the next one, PFA, I assume a lot of people on this Zoom call have already heard about it, have already maybe been exposed to it. Just as I'll put the professor hat on again, this is evidence informed. It's not evidence based. We can't ethically research it like that. We can't go into an area and say, okay, we're going to randomize a group of people we're going to help and people we're not going to help and see if it works. It's, a lot of time retrospective, a combination of qualitative and quantitative inquiry, but it's never in a very rigorous experimental designs, because we can't do work like that and get it through human subjects. Even if we could, I don't think it would be good to do. But it's informed by evidence, which is helpful, and it's espoused by a variety of different leaders and groups around the world. So the American Red Cross, the Red Cross Red Crescent, of course FEMA, all of the BHs, so the Minnesota Behavioral Health, or the Minnesota Department of Health, the DHs. I mean, everybody recognizes that the common themes across here are good for acute, in the very first initial phases of this type of work, like Courtney was saying. And it's based off the public health models with human resilience in mind. So we go to the next slide. The principles, if you go into the literature, you can find a couple of different variations on this. It's kind of like other things that have used like factor analysis type of methods to figure out where data collate. The guiding, the principal ones that you're going to see, sometimes you'll see this narrowed down into 4, sometimes you'll see this narrowed down into 6, but the principal 5 things, as you can see here, safety, comfort, connectedness, efficacy, and hope, are roughly in sequence, but they're messy. A really good way to not use, for example, Kubler-Ross's work on the stages of grief is to presume that they're all stages. And also that work was actually set up for the person that was dying. It wasn't set up for the people that were being left over. So the misunderstanding of a lot of this stuff can be a problem. So I just say that to make clear that the PFA principles go back and forth. It's not like you start with safety and end on hope and then you're all done. You go forward, you go backward, and you kind of overlap a lot of these as you go. So if we start with safety, in the moment, yeah, what's the practical assistance information? How can you present yourself or be with people, doing work with people, not on people, as a grounding presence? That you're listening to the concerns. Sometimes you're listening over and over again. You're repeating information over and over again. It's not uncommon for people to tell you the same story the sixth time, the seventh time, and the eighth time. Literally, it's the first time in their mind that they've told you when they heard the sound, this is what they did. And you don't go, oh yeah, you already told me this. I mean, you need to be empathic and offer that safety, because in their experience right now, they do not feel safe. And repeating the information, God, I've told you this 3 times. I've told you this 4 times. The water is over. It's the first time they've heard that. And that's important as you initially connect with somebody human to human, and a variety of different things, as you can put on your clinical skills is connect with that. This is my name. What is your name? What do you want me to call you? How are you doing? What's going on? What do you need? What are you thinking about, etc. And then as that overlaps into the next phases here of calm, by providing that sense of safety, you're starting then to overlap into this sense of, okay, this is a safer place now at the Family Assistance Center in the corner of this building where it is just you and me, and I can listen to you. We have 2 ears and we have one mouth, so that's a nice metaphor for listening more than oftentimes we talk. Therapists in training are notorious for this. Our graduate students are always worried, what do I say? A lot of times the best thing to do is to not say, but to engage and to listen. And don't push for other information. Oftentimes when we push for information in the context of trauma work, it's kind of because you're kind of a voyeur. You're kind of getting into the what happened, what was there, what did and that's for you. That's not for them. So you don't ask a whole lot of questions here. In terms of who was there, what happened, then what did you do, where did you go? The stress management techniques can be taught. They can just be walked through. Let's breathe together. Let's sit together. Breathe with me. Let's breathe in, and you don't have to explain that you're doing a 4x4 or a 782. Just breathe with me here. Close your eyes. Here, I'll close my eyes too. These stress management techniques can be didactic or they can be experiential. And a lot of times when you're doing the PFA, experiential is going to stick better. And then you roll with it. You roll with a variety of different ways that those types of things happen and those types of things go from one person to the next. That overlaps then into wisdom on what you don't do. And if we can just kind of pull up this whole slide, I don't know why it's coming up one line or the other. I think that's because my PowerPoint got weird. I'm sorry, Courtney. Courtney's the one that's advancing the slide. A lot of this is good therapy 101, so just think about it. But I think that the number one mistakes that people make, because oftentimes you as a provider are going to get kind of caught up in the moment too. Don't say that you know how somebody feels. You don't. Even if you too had a child that was in a school shooting that survived, even if you too, were in an MVA or motor vehicle accident, even if you too, whatever, you don't know how they feel. Don't tell them that it's going to be okay, because you don't know if it's going to be okay. Don't tell them that they did everything that they could, because most of the time they didn't. So to say, oh, you did everything you could, fight, flight, or freeze, maybe they froze, right? And if they froze, you know what? They probably could have done something, or, everybody could have Monday morning quarterbacked something. And I've talked with a lot of people in longer term recovery that were struggling more with this, you know what? I didn't do everything I could. So don't start it. Again, listen, be present, be compassionate with people in terms of that moment, and be careful about some of these kind of common landmines that oftentimes their family, their friends, their coworkers, other people that don't have training are going to tell them. So don't join the group of folks that are saying these types of things that can have longer term problems down the road. Connectedness with people, I talked about us being social creatures. Oftentimes when humans are struggling, we isolate. And you could take somebody that's got a perfect life, they got great family, great resources, great money, great health, whatever. You just pick something that makes your life great. And then if you could isolate that person, stick them in a room, shut the curtains and um, you know, uh, take them away from the world, it will not take very long for them to start struggling in terms of depression, in terms of a variety of different types of ways that humans decompensate, because humans need humans. People need people. And when you look at, consistent patterns of folks that are struggling with mental health. And if you look at across a variety of different types of interventions that we do, and it doesn't matter, I mean, it's cognitive therapy, cognitive behavioral therapy, solution focused, strategic, Milan, feminist, Bowen. I mean, doesn't. I mean, there's a lot of different ways to do therapy. Um, One of the common themes across this, outside of the common factors, which is, hope and expectancy and therapist client, relationship and all these different things. It doesn't matter what approach you're using, but still have huge predictive power in terms of clinical success. Is ask the question, where are your people? Uh, Family, friends, faith community, teachers, church, coworkers, because if it's all by themselves and they're seeing you once a week at 3 o'clock on Wednesday, or if they're only trying to get better from taking the medication that the physician is giving them, et cetera, we know that that doesn't work as well as when we start integrating different multimodal interventions instead of putting all of your eggs in one basket, for example. So, family assistance center, where are your friends? Put them to work, and this connects to the efficacy. That we've seen, for example, like where the bottled water is, and you're working in a family assistance center. Don't go get it for people. Put the teenagers and say, hey, go find some other kids and get water to everybody. That's human connectionness. That's human connection now. And it's also promoting that sense of efficacy, which is overlapping now into this other component of psychological first aid, that when you feel helpless, you still have agency. And we can do this in a variety of different ways. When we sit down with somebody, for example, you just ask them, would you like water or would you like coffee? Don't offer them one thing, because that's no agency. Give them a choice, water or coffee. Hey, do you want to sit in this chair or do you want to sit in that chair? It's kind of like in therapy. There's a big push over the last several years to not have the therapist have the throne, the fancy chair, and everybody else that's seeing them has the less fancy chairs. Have the chairs literally look similar in the room, and then the therapist is the last one to sit down, because you want to give the efficacy, the agency to the people that you're caring about where they sit. A lot of this comes from trauma work. Your house is gone. You don't know where your companion animal is. Your dog might be dead. The phones are down. We still can't connect. There's nothing about your world right now that feels in your control. But you know what? You can at least choose water or coffee. You can at least choose where to sit down. These are subtle ways in PFA that we're starting to promote efficacy in a stage setter type of manner that can influence the clinical course of what's going to go on next. So if we go on then to the next slide, ultimately what's happening, and again, you're going back and forth across all these different things, is that you're instilling hope that there is new. We're never going to go back to the way things were. Time only goes forward. Time doesn't go back. But that there's new normal functioning, and you know what? You are a part of that. You are an active participator now, instead of a passive recipient of what happens. And so, yeah, let's go find out information about X, Y, and Z, or when is that next situation report or sit rep that's coming up. Let's find that, because I want to find out when I can go get this, or how I can access this, or wow, that's a lot of information. That's so cool that you figured that out, highlighting different types of strengths. And as people, and they will, go into kind of these loops of, what if, what if, what if, what's next, yeah, but, all these kind of ways that we can get stuck. We go back to the facts, so the fact finding, and then figuring out some kind of it at least sense of momentum into something different. And then you go back to listening, and then you go back to, promoting the efficacy again. And then you go back, again, as you're going back and forth here, there's this gestalt of things that are happening where ultimately in that moment, people are feeling, and they can't necessarily articulate it this way, but they're feeling, okay, I am responsible for some of what's happening to me now instead of all of these things happening to me, and maybe I won't get PTSD along the way. That was nice to know that so few people actually get it. Thank you. Now I feel more hopeful, maybe even in just in terms of that. So if we go on to the next slide, putting all of these things together, you also want to be prepared because there always are some people that really are going to tailspin. And in the ways that our MRC and other response organizations work with disaster behavioral health, again, we have multidisciplinary representation and interdisciplinary collaboration happening. So if you're seeing, and most of us are trained in different ways to intuit when referrals are necessary, that who and how and where can I connect with others in the team to do right by people that are potentially in a place that is remarkably unsafe. We in our teams have folks, and we have infrastructures to do this. If in the moment you're not quite sure, connect right away with your team leadership and incident command, because this is part of the ways that we're set up to do right by people that are not necessarily going to be as amenable or as like the clinical match. I guess that would be an academic way of saying it to the previous slides that we had on PFA proper. So we go into the next slide. It's important to see, I've already said this, but I think if you walk away with anything on PFA, just recognize that these aren't, step 1, step 2, step 3. They're processes, they're not events, which then evolve over time in a variety of ways that's important to understand. And that's reflected here in the next slide. This is a messy graph that I think a lot of folks have seen. And if you go into literature, I'll put the professor hat on again one more time, you're going to see different versions of this as well. But the pattern is the most important. And that is, oftentimes, and humans do this, and I think it's adaptive, and it's also a problem. That after something has happened, we do try to get back into some kind of baseline. It's because we can't live day to day with this hyper vigilance of fear that would just burn us out, burn us all out. But when something happens, you can see that there's this impact. There's a variety of kind of resources and energy that immediately go on. There's this honeymoon, ta-da, look what we're doing. And then afterwards, it's kind of like the day or week after like a wedding that you've been planning for a year, or you've been working for years to get to that license, and now you're like, well, now what? What's my next degree? Or there's oftentimes this kind of lull on disillusionment, that the crisis is over, the rest of the world is on to the next news story. They've forgotten all about the shooting at our church, for example, because there's been several shootings at other churches since then. And we've already actually even seen that with the Annunciation work, with different, of course, triggering events and then ultimately reconstruction. We present this not as like, this is something we're going to test you on, but just to understand that the ways that PFA and PFA principles overlapping into, for the minority of people, hear that very clearly, the minority of people that do need long-term care, it's going to look different. You don't do clinical work the same way with anybody at 2 points in time, potentially, in terms of their own growth and development. And so it's important to just understand temporal context. It's good if you can connect different systems, biopsychosocial, spiritual, in terms of the systems that our folks inhabit, or the systems that inhabit them. But also think about time, think about when, because a lot of those systemic frames in terms of the care we do are good at the different systems, biopsychosocial, spiritual, but they miss what we call the chronos system, which is time, because the very same thing might look different today than it'll look in 6 months. So if you go to the next slide, that's where I'll pass the baton in terms of what a lot of this looked like with the larger infrastructure within which the oftentimes one-on-one support and then everything in between that we were up to panned out, manifested, and in a lot of regards is still continuing, or at least in different ways that we're prepared to continue. Courtney.
Yeah, thanks, Ty. Just, sort of a trigger warning. I hate saying that word, but sort of a trigger warning here that we won't be talking too much about, the details of the shooting, but just to know that we will be talking about how this shooting affected the community and the families. And Ty, just feel free to jump in whenever you need to. So we know that the shooting occurred on a Wednesday morning, August 27th, during Mass at church. And the immediate needs and the immediate response and all of that was handled at the scene and near the area that the incident occurred by first responders and by others that respond to a scene of an incident. um, all of us in public health and human services and other areas, we're not going to be those people that go right to the scene. We're going to start to think about what do we need to do a few days down the road, should we need to have some sort of assistance center for those impacted. So neighborhoods of Minneapolis asked for a neighborhood assistance center. And what that was, or why they wanted that, was because, Minneapolis is a tight community, I would say, and especially within individual neighborhoods. And so neighbors wanted to help. They knew people that were part of the shooting. They knew people that were part of the shooting, like Ty said, kind of um, trying to put themselves in that incident. And I would say that many people, instead of, 3 or 5 degrees of separation, they maybe had one or two. And so this really affected the neighborhoods. And so the city of Minneapolis decided to activate what they're calling this neighborhood assistance center. And this ran from Sunday, August 31st through Tuesday, September 2nd, Labor Day weekend. And what we were asked to provide as the University of Minnesota Medical Reserve Corps were licensed mental health providers. And they wanted our licensed mental health providers to be able to provide psychological first aid and psychoeducation. They didn't say that to us, but we sort of, that's what we knew that we were going to have to do. So this is a photo, and you'll see Ty standing there with his purple vest on, of the Neighborhood Assistance Center. So it was located at Lyndhurst Recreation Center, part of the city-owned Parks Department, I believe. And it was meant to serve as a resource to the community members. So we weren't really sure what to expect when we got there and who would actually seek services and how busy it might be. And so the first day was just sort of, we didn't go in blind, but we went in just not having an idea yet of what the needs were for this population. And so we, I think, I'm going to go to the next slide. We had Ty in the middle and then Joy on the left. There are disaster behavioral health response team leads. And then Tanya on the right is the director of our Pet Away Worries and Stress program, or PAWS, which is an animal I don't, Tanya doesn't like it when we call them and call it animal therapy, but animal assisted support. And you'll see that we wear these purple vests, and the purple vests are meant to be a visual identifier of someone that can provide mental health support. So what do we do? Um, and Ty, jump in here because I think you can provide the more specifics. Obviously, I'm not a licensed mental health provider, so I wasn't doing the direct intervention. Although I will say I did do quite a bit of PFA. And then at a certain point, I would sort of say, you know what, let's go talk to Ty, or you know what, maybe Tanya can help you a little bit, talk through that a little bit more.
Yeah, I can jump in there as well. I mean,
Yeah.
one of the nice things about PFA, nice and also I think essential, is every member of teams that deploy or are in any kind of context of a push intervention or a pull intervention are trained in PFA, because you could do this in the parking lot, you could do this in the entryway, you could do this as you are passing the baton, like Courtney just said, to somebody that has more of a mental health baseline, because it's going to be a longer conversation. And the overlap between the PFA principles and psychoeducation. For example, the majority of people that go through trauma don't have PTSD. I mean, that's a psychoeducation type of conversation. That oftentimes will certainly be more, or at least more naturally advanced by the clinical folks. And then people need people. And so we're not going to meet necessarily one-on-one with everybody. And a lot of times in the context of groups, parents that shared wisdom, that shared experience of being a parent who is worried, who is afraid, who is wondering, fill in the blank. We facilitate groups, and that's oftentimes connected then to that baseline clinical training as well, because most trained clinicians are, at least hopefully in terms of the school that they went to, but then in different parts of their life are skilled or comfortable with more than one person in the room. And a lot of times in that regard, you are exactly that. You're facilitating, but then you're getting out of the way as parents are helping to support other parents, or and not necessarily just with this response, but people with shared identity. Coworker is supporting other coworker, for example. Neighbor is supporting other neighbor. And then those are all, again, always facilitated. We had printed resources like how to talk to young children, ways to engage teenagers, because those developmentally are very different. And a lot of times, activities, I would say, for kids, but also adults, sometimes it's easier to engage with people when you're doing something. A lot of spouses will say, for example, we have some of the best conversations when we're in the car, because we're looking straight forward, and we're like, or we're on a walk, and maybe being distracted. Here we go on the table, by some of the artwork or whatever. We're doing something, but then we have really rich conversations in comparison to looking straight into each other's eyes and saying, let's talk about what's going on.
Yeah, and so a little bit more about the structure of the neighborhood assistance center. So this photo is showing the kind of table that we set up in the gymnasium. So the gym had our MRC table. It had some other just like city city neighborhood volunteers that came in and brought different supplies and games and all kinds of stuff. And then there were two programs, one Hennepin County Attorney's Office Victim Services Division and the Office of Justice Programs at the state, who were there to assist eligible people in getting certain types of financial compensation. So when a crime happens and you are going to lose work hours at work, or now you want to seek therapy after the first few weeks, you feel like you could help benefit by therapy. those are the kinds of things that those programs can help provide to the people that were involved in the incident. I don't know exactly. I never asked them like the complete eligibility, but I know that for this incident, they did expand the eligibility for these programs to people that were not like directly impacted, like were in the church or were a parent of someone that was in the church. But they also extended it out to sort of the immediate neighborhoods and community around um, the the shooting at Annunciation. That was in the gym. This was kind of like their little lounge in the front, which I actually thought was a nice place. Lots of light and just sort of a calming area with little plants and stuff like that. So um, I sort of expected that people would want to kind of sit in here and talk, but I mean, I was actually kind of surprised that it wasn't really used that much. But it was also a really beautiful day or beautiful weekend. And so a lot of people were, hanging out outside or, um, in going through the gym, but then going back outside to just be, to just be. And that was kind of my observation of all 3 days that we were there. This was our group on Labor Day. So you can kind of see that the first day we had 3 people. The second day we had 5 plus a lead, Catherine, on the left. Um, and we tried to just sort of assess based on the current demand that day how many providers we would need for the next day. And overall, we I did staffing day to day. And the other reason was because we needed to have an official request from the city of Minneapolis. So that was our chain of command in order to uh, bring our teams to the site. So we did not show up uninvited. We were not spontaneous volunteers. We waited for an official request from the city of Minneapolis to come and provide these services at the Neighborhood Assistance Center. So, all of that is to say that, sort of day to day, figuring out how many people we would need for each shift. I think overall at the Neighborhood Assistance Center, we saw maybe 150 to 200 um, households. I don't know how else to explain it. Some were individuals, some were families. A family was considered one encounter. And so that was, pretty decent
And I,
for,
if I just
yeah.
jump in, I just love this picture too. We should put captions because we have different disciplines. We have public
Mhm.
health, we have psychology, we have family therapy, we have social work, we have psychiatry. Um, Different sibling disciplines do better work when they work together. I've already said that, but I cannot say that enough. I think in everyday practice we can isolate, but in collaborative and integrated care and in trauma work we don't because these teams are better by nature of their disciplinary diversity um, with common themes of PFA connecting them.
Ty, do you want to talk about this a little bit?
Sure. Courtney was just talking about that nice space inside, not having a whole lot of traffic. It was a beautiful weekend. And it was in this context, as you can see here in the pictures, that we did some of our most engaged work with folks. And this was in groups standing together. I had a couple of meetings with folks just under a tree. The animal assisted or the therapy animals oftentimes were really helpful in terms of facilitating some of those conversations. Some of the parents that we talked with, two different times, I had parents say this is the first time my child's talked, and it was because they engaged this beautiful angel with fur in the form of a dog that helped to do some of those initial connections. And through that, then emerged a conversation, kind of like, the couple driving in a car, like I was saying. that when there was an animal there to love on and to snuggle with or to scratch behind the ears, then we were able to have some really um, meaningful conversations with folks that I don't think maybe otherwise would have happened if it was human to human only. And so we were this is across the street. There's you know a park. And we had some meetings just kind of hanging out on the swings on the jungle gym. And you kind of you meet people where they are, and it speaks to in my opinion also the value of those push interventions where we go to them versus them coming to us on our turf.
Were you and Tim also handing out
Yes, the flyers,
flavors?
information, etc. We had though we weren't like annoying like hey take the flyer, but as we were connecting with different people, we certainly had them. They came up in different ways and different conversations with folks. Sometimes we didn't because it maybe felt disruptive. Other times, here's a resource you can take or leave it, or yeah, you have one child at this age, another child at this age. Let's talk. Here's a resource that talks about some of that. Um, but we always had them, and I think that was a nice way to facilitate some conversations that might have otherwise felt a little awkward.
Ty, not to get into any sort of details, but sort of an aggregate, what were some of the most common themes or questions that you were getting when you were working with people or
I
families?
yeah, the most some of the most common ones with parents were uh, how do I uh, should I, and then how do I have conversations with my child about this? They're talking with their friends. Is that good enough? Should I get out of the way? I'm listening. It sounds okay. I maybe want to get in there because I'm the parent, but I'm not quite sure what to say. Um, is it okay for my child to go back to school? Uh, am I making it worse by being super afraid and saying don't go back to school? Am I pushing them to, do something that they don't want to? How do I navigate that? Where the kids were oftentimes really worried about their friends. They oftentimes would talk about their friends more than they would talk about themselves. Um, they wanted to be with their friends, and I think in a lot of regards, the older we get, the more isolated we get. Kids are kind of by design in their day with school and classes, able to access social support a lot anyway. And how and in what ways, my friend is sad. What do I say? Or I love, and we heard about video games a lot or different things like that. Yeah, we're they didn't say the word connecting, but we're connecting through our games and through play, and that's really cool. And then you don't jump in there and necessarily do anything other than to be that compassionate presence and applaud what they're doing because human connection is part of PFA. So you just you kind of cheer that along the way. But that's my long-winded way of saying it depended by
Hmm.
age and by what was going on. We did notice, and this is consistent with what we know by binary gender, is that the girls seemed, at least in the initial phases, more connected with their friends. And like the two examples that I talked about where the animals actually facilitated the beginning of conversations, both of those were boys. I think we socialize boys to be tough, um, where we socialize girls to be more, well, social. And I think that the invitation and the permission giving for some of the boys was coming up a lot more.
Hmm. Yeah, I saw a little bit of that too when I was at the Family Assistance Center. I'll talk about that in a second. But one thing, so this I think was our Tuesday crew. Um, and one one of the main things that for me as a medical reserve corps manager was I guess not surprising, but pretty welcomed was that the day of the shooting, I was contacted by the department chair of our psychiatry and behavioral sciences area saying, "We're ready to help." And I said, "Okay, well, I'm so glad you're ready to help, but you have to be part of our medical reserve corps in order to be deployed with us. And that's, legal and liability reasons." And so we quickly invited people to apply to be or to join our medical reserve corps. And then we were able to quickly deploy them. So in this photo, on the far left is Gene, and he was like one of the VIPs. And then to his right are Alex and Sophia, and they are psychiatrists and researchers. And one of the questions that I got from them before they were deployed, and actually a couple of other of the faculty members, were how how do we like what are we supposed to do when we get there, right? So like Tai said earlier, they're so used to having patients come to them and they deal with an individual patient, and that clinical process with individual patients. And so I think that they were a little had a little bit of anxiety, and Sophia did tell me she did use that word anxiety of, and interestingly, she's an anxiety specialist, um, that she just didn't know what to expect. And so she had that anxiety going in. And I said, you know what, Sophia, we all have that. Even if we know, like even me, 20 years of doing this planning and responding, there's anxiety going into anything. And so I think even our team was, having their own feelings and their own responses and their own, like, even physiological responses to um, going to the site, and then how they were interacting and working with people at the site. So that was a long way of saying that, if you're a medical reserve corps unit, you're probably going to get a lot of people that want to, sign up and go help right at that time. And obviously, as Susan knows, that it doesn't happen that way. It doesn't happen that quickly. And so one of the messages that we're going to use with to help sort of recruit more members after this incident is that, we need you to be um, verified and credentialed ahead of time so that we know who you are, so that when we deploy you, we are sure of your license. And then we've at least given you a baseline amount of training before you go into a response like this. And that kind of baseline training helps ease people's minds a little bit and give them a little bit of confidence going in. And then once they get there and they're part of this team, they have each other, they have their team lead, and they can sort of just work together to do the best work that they can. So on Tuesday, the last picture was Tuesday at the Neighborhood Assistance Center. About halfway through the day on Tuesday, we got requested for half of our team to go over to the Family Assistance Center. They were overwhelmed with families. So this was Tuesday, the day after Labor Day, which we sort of anticipated we might see more people that day if people had been out of town for the holiday weekend and now they're coming back on Tuesday. Especially the community members, we thought that we might see a lot more people at the Neighborhood Assistance Center on Tuesday. But the Family Assistance Center got really, really busy. And so we kind of split up our team, and half of us went over to the Family Assistance Center. So the FAC, the Family Assistance Center, was a private by invite only location for the families that were directly impacted. So the kids, their parents, and sometimes grandparents, and then others that were in the church at the time of the shooting. It ran, or our time there was Tuesday the 2nd through the following Monday the 8th. And I think had been active, I think starting like, so the incident happened on Wednesday, I think Friday, Thursday or Friday, the city had activated it with, along with the archdiocese, for the families at a sister church. And then again, the request was the same, that they wanted us to, provide our licensed mental health practitioners. So the Family Assistance Center, it was kind of jointly managed, I think, between the archdiocese and the city of Minneapolis. So without getting into a lot of details, there was a lot of confusion. And I mean, the families didn't know this, but for those of us who were working there, providing support, there was a lot of confusion over who was in charge. Like, is it the archdiocese? Is it the city of Minneapolis? Is it somebody else? Um, and thinking back to our PFA principles, for us as responders, not knowing who is in charge, not having a good chain of communication, like who do I ask if I have questions? Who do I check in with when I get to the FAC? How do they know we are who they how do they know we are who we say we are? All of those questions that as a responder, I want to make sure that I know so that I can support my team. Um, that caused a little bit of kind of that initial anxiety for me, because it just wasn't, there was too many unknowns about what who was in charge and what kind of what was expected of us. And so our disaster behavioral health response team, we just had a tiny piece of this larger picture, and we only had sort of control over our team and how we managed our mental health response at both the neighborhood assistance center and the family assistance center. It was a little easier at the neighborhood assistance center because we knew who was in charge and it was sort of a smaller um, facility. But when I got to the FAC, it was just kind of crazy. Um, so for those of you who uh, know a family assistance center as more of a fatality management place, so those of you in public health and human services that have been planning for FACs, um, kind of generally accepted definition for an FAC is, to assist the medical examiner in identifying fatalities and making death notifications. This was not that. We didn't do any, the medical examiner was not involved at all in the family assistance center. This was purely what I would just consider an assistance center for families. That's a little confusing and that's a little inside baseball, but just wanted to make that clear for those of you who are watching that actually um, know the high, like the concept of a family assistance center as it supports the medical examiner. So this is our table when we first got there because it was just a mad rush and a mess. But what I wanted to say earlier when Tai was talking about the kids and how the kids just wanted to be together. And so when we got there on Tuesday, we understood that this was the first time that the families and the kids had been together since the incident happened. And so um, the place was just chaos, but like in a good way. So kids were happy. They were playing with each other. They were, hugging each other and saying how happy they were to see each other. The boys were, throwing balls and wrestling on the floor, like literally. And so that, like for me, that sort of created a weird feeling of knowing that these kids and these families have been through such a horrible tragedy, but yet they're experiencing joy, like they're having fun together, they're smiling. And so as a responder, from my personal perspective, um at first it just kind of felt a little weird to me, but now going through all of this and understanding the sort of process that kids and families go through with something like this. It made total sense. It's just another part of a picture of our table. This was the second day. We were a bit more organized. Um, we had lots of like little fidgets. We had like the kind of little bowl on the left side of your screen was cotton balls that we had these little essential oil rollers that people um, really liked. We had coloring sheets and markers and crayons. We had bracelet making things that was hugely popular. And then I went out and bought some bubbles. So that's what you see kind of on the front right side of the table. And just sort of learned the day before what might be well received by the kids. And so we sort of took the role of being able to keep the kids busy while the parents were able to talk to one of our mental health providers. There are also other mental health providers there, but I'll just speak for us that um, we intended to have our space be a place where the kids could be distracted for a little bit, and so the parents had a chance to go talk. And I will say that some of the parents did not want to you know, leave their children, or they wanted them to kind of be in eyesight. So we were just trying to, accommodate whatever we could and give them that sense of safety and that sense of calm. Um, let's see. We're at 10:20, so I want to save some time for questions. These are just more photos from the FAC. Beanie Babies were a hit. You probably can't read these, but these handouts on the front of the table were parenting after violence, what to expect, a list of recommended books, some other just sort of tips about the progression of, uh, you know,
And if
mental health. Mhm.
I could just jump into, I mean, also as part of our responsibility, I mean, the handouts that we distributed and the different resources, um, empirically supported stuff. I mean, everything being connected with empirical research, and not just one study, a culmination of existing knowledge connected to this and a lot of times refereed journal articles or textbooks are really difficult to consume. They're written in very academic language and are not certainly even findable unless you're in the academy and have the appropriate kind of electronic connections and subscriptions to it. So this is translated into layperson language that is easy to read and consume. Not the opinion of one, but the opinion of existing science and knowledge connecting this not only in terms of acute but in then long-term recovery and on information that people can benefit from in terms of knowing or connect dots as they go forward.
Yeah, and the
Putting on the
handout,
professor hat again.
yeah, the handout that you see that kind of has the little rainbow on the top, Parenting After Violence, Strategies for Resilience, that is what our team used as sort of the basis of the parent groups. So they would go through that handout and a couple other resources, and then just have time for the parents to process. And we started those groups kind of at the end of the week when we were at the Family Assistance Center. And then again, the therapy animals, there were two alpacas there. Whiteout is the name of the white one, and Reese's was the name of the brown one, and they were sort of a hit. And then I just want to say that as far as our team and making sure that we're taking care of each other, we tried to just do daily check-ins or kind of ad hoc check-ins with each other as we were going through. And then we did last week two psychological debriefs of our team. Um, And so again, we always want to make sure that we're taking care of our own people and they're not burning out or just, having their own levels of stress that make their job harder to do. So that I'm going to stop sharing because I can't see the chat unless Ty, you can see the chat. If there are questions that we can answer
Yeah,
in the
I could
last
just jump
minute
in.
and a
I've
half.
noticed a couple of questions coming up on the chat, so let me just respond to them quickly. I mean, Courtney, you just started to talk about this, but some folks had asked about like what we were doing with first responders, and I would overlap us into that. Um, the we always work in even numbers. You know, you never want to go to Valley Fair or Disneyland with 3 people or 5 people because one of you's on the roller coaster by yourself. I mean, everybody is in twos. We do that across disciplines, like I say, but this is also so you can have personal check-ins, debriefs, support offered throughout the day, you know, as we're working in these deployments. At the beginning of the day and at the end of the day, you know, as a group to process with each other, have debriefings about things that were coming up, struggles, wonderings, ideas, resources, and just really the process of that you're not in this by yourself and that we're supporting each other was huge. First responders as it connects to police, as it connects to uh, emergency EMT responding personnel. That wasn't within our scope, although we certainly talked with folks. We had law enforcement present at these at the neighborhood assistance center, especially where we certainly did PFA with them, you know, and we were talking and the different things that they were doing, you know, alongside or behind the scenes are not something that we were privy to. I hope that they did. I don't, again, know the details, but we certainly know that that is a culture in and of itself. There's a whole literature on how to work with EMT and law enforcement, fire, etc. I hope. I don't know.
Yeah, we did. I mean, I offered multiple times to be part of any sort of debriefing for the first responders. I think it was Monday, Labor Day, when that police officer was, just walking by the neighborhood assistance center, and I just, asked him, "Hey, would you like a bottle of water, um, a snack?"
Yeah,
And so we gave him that, and he did. And I just said, "How are you doing?"
yeah.
And he did say that he was okay, but a lot of his colleagues are pretty traumatized. And
Yeah,
um,
and my understanding was that they were responsive to that, but who they are and what it looked like, that was, you know,
mhm,
I don't know.
yep, they
Yeah.
wanted to do it themselves, is what I was finally told. That they wanted to handle it internally, and we said, "Okay, that's great. We're here if you need anything
Yeah,
from
and
us."
that's not uncommon. Sometimes there can be a better sense of safety when it's one of your own, you know, that facilitates some of that. So
Hmm.
I'm looking at the chat. The flyers that we distributed, different resources that we did, can we make those available? I'm perfectly happy making those available. Those are all, again, empirically supported, publicly um, available in terms of that format. If people want some of the original sources that are a little bit more difficult to access and to print, you know, again, unless you are within a university or an academic institution, you could certainly send me an email and I'm happy to go get them and send them to you as attachments.
Hmm.
Absolutely.
Yeah, I have them all, or maybe I can just send them to Susan, so she has them,
Yeah.
and we
And
can. Yep, we'll
yeah, I
also
was going to
share the
say, and
PowerPoint.
alongside the PowerPoint, yeah, yeah. I mean, certainly we could share the PowerPoint with anybody that wants it to.
Yep. Um, I just see that Dick Fuller put in the chat about chaplains, and I forgot to mention that. So at the Neighborhood Assistance Center, they did have um, a pastor and a rabbi the first day. And then once we were over at the Family Assistance Center, it was in a Catholic church. So there were a bunch of priests there that were just sort of available if people wanted to talk to a priest versus one of our mental health providers. And that happened a couple times. Someone asked me, um, if they could talk with a priest. And so we just sort of facilitated that and made that happen.
And that would be different than, I mean, chaplains as part of MRC and response teams are not aligned with any particular faith or any particular denomination within a faith, and their role is a lot more flexible in that regard. But priests specific to a specific church or a specific denomination, that is those are different paths. So yeah, we were absolutely trying to facilitate what people wanted, because there were a lot more than one choice as it connected to that.
Yeah, and then I'll just maybe answer one last question because we're at time, but Sharon asked what other services besides disaster behavioral health were provided prior to 8/31. Um, I don't know, Sharon. We weren't involved until the 31st. I do know that the Family Assistance Center was set up either Thursday or Friday. And again, it was I think a joint partnership between the Annunciation School, the Archdiocese, and the city of Minneapolis. And I believe it's, the same services were provided from beginning to end. All right. Thank you for attending. I think at one point I saw about 150 people on. So we really appreciate it. We hope that this was helpful. Um, if you have other questions, Susan will have our information. I'll send everything to her, and she can distribute as necessary, as well as the bios, the objectives, and whatever else you might need for your CEUs. All right. You want to stop recording now, Tai, before we hang up?
And thank you, Courtney and Dr. Mendenhall. We really, this was wonderful, and we can't